Hi, good afternoon. Can everybody hear me okay? Yes? Great. And I will try to remember. I was here Tuesday and I spoke and forgot to change the slides, so I'll try to remember to do that. So I'm Joe Clift. I work at CMS. And what I'm going to talk about today is the Experience of Care survey that my division developed along with RTI, Research Triangle Institute, that had the contract to develop the survey. See, I forgot to change the slide again. Here we go. So the contract was to develop an Experience of Care survey for the LTAC, the long-term care hospital setting, and the IRF setting. So they were developed at the same time, but what I'll talk about today is the IRF component. There was a lot of overlap during those survey development, so I might bring in some of that as well. But RTI had the contract to develop this survey, and there is not an existing survey looking at experience of care in the IRF setting that's in the public domain. I know there are some vendors that have some proprietary survey instruments, but there was nothing in the public domain. And so CMS sought out to develop this survey, kind of modeled after, you might be familiar with the other CAP surveys. Modeled after that, we followed the CAP's standards for survey development and also the CMS blueprint for survey measure development as we develop this survey. So I'll go through a little bit of how we developed that survey, questions that are on that survey, etc. So the beginning part of the survey development, this was started in the fall of 2015 through the summer of 2016. And what we did is we set out a call for measures in the Federal Register. So we were looking for information from the public about questions that should be on such a survey, existing measures, looking at experience of care for the IRF setting, etc. So all of this that you see on the slide here was all part of how we began to develop this survey. We conducted a literature review, but we had a lot of focus groups with patients and families all around the country. We convened a technical expert panel consisting of patients, patient advocates, clinicians, etc., researchers, to find out what is important to them, what is important to the patient when you're talking about experience of care, and specifically the IRF setting, because the existing surveys that CMS has developed were for acute care hospitals or for home health, etc. So there was nothing for this. So we really wanted to learn what exactly do we need to look at when we're talking about experience of care, and what are those questions we need to ask, and what kind of answers do we need to provide on those for those questions so that we can get at that experience of care and to assess quality. And we also conducted cognitive interviews, which is in survey development is where you're doing interviews with people to make sure that they understand what you're asking in the survey, to make sure the questions aren't ambiguous, to make sure that what you are trying to get out of them is that they're able to tell you through that survey question. So we did a lot of cognitive interviewing just to make sure the survey was clear to the people taking the survey, and we got the information that we were seeking. So the IRF questionnaire, the sets of questions that are on this look at these areas right here: goal setting and monitoring, specific questions asking about care received from all these different health professions. And what's different on this survey versus the LTAC survey, for example, is within the IRF community, a lot of patients might see physical therapists, or they might see speech-language pathologists, or they might see occupational therapists, and maybe not others. And there was a lot of discussion in our TEPS and discussion with patients that we really needed to tease out the experience with the communication that patients and their family receive from these different levels of providers and these different provider types, instead of bundling them together as like maybe all therapists, for example. And they felt that that was really important because in these settings, a patient might spend a lot more time with an occupational therapist than they might with their physician. So getting at that piece of information about how that experience was with that occupational therapist would be very important. So for this survey, compared to other ones, we really got down into the various different levels of therapists that a patient might interact with. We also have questions about experience and the environment of the facility. So was the room kept clean? You know, that sort of questions. Discharge preparedness, overall ratings of the IRF. So your likelihood of recommending the IRF, your overall rating, you know, considering everything, how would you rate this IRF? And then also questions for demographics of the patient and also the proxy. And what I want to just spend a second talking about the proxy, for example. So for this survey, similar to what we have on the LTAC survey, this is the first survey the CMS has developed that a proxy can take the survey on behalf of a patient. So that means that if a patient is unable to complete the survey, maybe they're incapacitated in some way, a family member or caregiver familiar with that patient's stay can take the survey on behalf of the patient. And that's very different from some of the other CAPS. No other CAPS survey allows that. And what we did is we tested the patients taking the survey, and we also tested family member familiar with that patient's stay took the survey. And that's how we conducted that analysis to see if their level of agreement with those same questions. So for the survey testing, there was two types of testing that we did, and these are the aims for what we sought to accomplish with the two different tests. And some of the IRFs that you might represent, maybe you were part of the field test or the mode experiment when we were testing this. But the aim of the field test is to conduct the psychometric analysis to test the reliability and validity of the survey. So basically what we're trying to do is make sure that that survey is measuring what it's intended to measure. Evaluate the level of agreement between respondent types, patients, and their family member or caregiver. So we're comparing, looking at different groups of people who took the survey to look at levels of agreement, assess the reliability and validity, and also to test the consistency of the survey items. And all of this is done to start to develop within a survey these survey-based measures. So like for the hospital CAPS, for example, what we use in CMS, you might have 10 questions and all of those are compressed into a single survey measure. And that's what this survey is that all of the questions that are dealing with maybe discharge, that turns into a discharge score for those survey items. So that's what we're talking about when we're trying to make sure that this survey is doing what it's supposed to do, so that when we have those survey-based measures, those are reliable and valid. After that's done, the mode experiment is where we test the survey procedures as if the survey is going to be administered in the setting, validate the composite structure of the survey. So those are those survey-based measures that I was talking about. And then also create the model for the patient mix adjustment. So this is where you take the scores from the surveys and you might apply some adjustment factor to them to make sure that when you are evaluating, you're putting IRF facilities like sort of on a similar level playing field, for example. So if one IRF has much sicker patient population than another, there might be an adjustment factor for that. So if you're comparing IRFs together, you're not doing an inappropriate comparison. Well, this IRF has a lot more of this type of patient than this. There's an adjustment factor that goes in there to try to make it level the playing field, basically. So for the actual testing, the field test we conducted between September and December of 2016. We had 41 IRFs participate in that. And that one we tested mailed survey, telephone follow-up with surveys that weren't returned in the mail. So those, if we didn't get one back, or our contractor didn't get one back, they would telephone the patient and ask them to take the survey on the telephone. After that, we conducted the mode experiment during June and August of 2017, and we had 65 IRFs participate in that data collection. And that one we tested 3 modes: mail only, telephone only, and mail with telephone follow-up. And that we had about almost 2,300 completed surveys back from that. So that was a pretty sizable return that allowed us to conduct the analyses we needed to assess the reliability and validity of the survey. So those survey items that I was talking about, this is what these are here on the slide. There's 4 survey-based measures that are within that survey. They cross 4 areas, and there are 2 global ratings. So the first survey item is goal setting and monitoring. So those are all of those questions that are asking about the patient's goals, where they set, et cetera. All of those questions compress into that goal setting and monitoring. And then we have all of the communication with staff. That's another survey measure, and that's all of those questions compressed, dealing with communication with the therapists, the nurses, the nurse aides, the physicians, et cetera. The other 2 are experience at the IRF and preparing for leaving the IRF. So that one's getting at all of the discharge information, preparing that patient for leaving the facility, and assessing that experience, that the patient's experience with that process. And then 2 overall ratings: the overall rating of the IRF facility, and then also the recommendation rating, considering everything, would you recommend this IRF? And again, the survey, as I mentioned before, allows a proxy response. So what we found is within the IRF, why we allowed this is when we were doing the information gathering phase, we saw that there were, the data suggested that there could be up to 20% of IRF patients who would not be able to complete the survey due to some reason, or remember some of the, maybe why they were at the IRF at the beginning when like the goal setting questions are, when the goals of their care are being established. So we allowed the proxy to complete the survey, and what we found is it was about between 30 and 40% of some of the surveys we got back were completed by the proxy. And if this was, if we didn't allow a proxy, we're talking about taking that 30, 40% out of the picture and not having that information to assess experience of care. So that's why this allowing the proxy was a really important thing for this particular setting. And for the overall survey, we use Cronbach's Alpha to assess reliability. So that's a statistical value. Anything above 0.8 is considered good reliability. And for the whole entire survey, the reliability is 0.95. So what that's telling us is that this is a reliable and valid survey for use in this setting. And what I would just talk a little bit about is the next steps. So as I said before, the survey itself was developed for use in the public domain. So it is free for IRFs to use as they choose to. CMS at this time is not proposing the use of this survey in the IRF Quality Reporting Program. And so what we wanted to do is at least make that survey available to IRFs should they want to use the survey. I know a lot of IRFs that participated in the field testing and the mode experiment were really interested in the survey because they didn't have one, or they maybe had a vendor that they were paying money to use a survey, et cetera. So this is a survey that was developed and validated for this particular setting, and it is in the public domain. It is on this website here on the IRF Quality Reporting Program page, and then on the left-hand navigation you'll see IRF Patient Experience of Care. So on that we have the English survey and the Spanish survey. We have the cover letters and the telephone script all ready to go for you to use as you will. The only thing, because CMS is not mandating the use of the survey in the quality reporting program, is we cannot assist with IRF using the survey, so we can't answer questions about maybe data that if you use the survey, you can't send us data and ask us for like analysis support or that sort of thing. But if you do have some basic questions about the survey, there is a help email address on the website here that you can use to get some information that you might have about the survey, and then we'll figure out. If you ask us a question we can't answer, certainly we'll say we can't answer, but we definitely wanted to make sure, this was developed. We wanted to make sure it was available for people to use, and so that's what I wanted to share today. Did anybody have any questions about the survey or? Yes? A question? Oh.
Because certainly telling people isn't working, right down to changing uniforms. So we don't know, because we want the results to be valid.
I'm sorry, could I ask you to repeat that so everyone can hear you? Thank you.
In my facility, we found that it doesn't matter how often the patient has been educated on the role of the provider. When occupational therapy comes into the room to work with the patient inevitably says, I've got to let you go, my physical therapist is here.
Right.
We reinforce, this is occupational therapy, this is what occupational therapy does. Physical therapy and speech therapy do the same things. Our facility is looking at mechanisms in addition to this, including changing uniforms, additional name badges. We're looking at everything we can, because patients tend to lump all therapy in with physical therapy, and that gives us, we feel, some skewed results. And I just wanted to get your thoughts on that.
Yeah, so what we did in the survey is for the questions preceding the different staff levels, there's I can't remember the exact offhand, but it's saying that this person might have done X, Y, and Z to sort of prompt the patient or the proxy responding to the survey to think back to the particular person who might have provided that service. So as a cue to them when they're hopefully taking the survey, not doing that lumping together. So we did add those questions. What we found is this did come up when we were doing the focus groups, that's why we added these questions with these prompts about your nurse might do this or your physical therapist might do this, so they could differentiate the who from the what when they're doing the survey. Because this did come up about people like, even within nurse and nurse aides, it was a lot of lumping together. And there's a huge difference between level of skill, and we needed to make sure we tease that out. But also make sure that we captured, like the nurse aide, for example, who a patient might spend a huge amount of time with, much more than anybody else in the facility, but we wanted to make sure that they understood that person who was providing that service understood that that's what they did versus someone else. So as you'll see in the survey, we do have those questions laid out like that to try to identify that, and hopefully that, but we didn't, from the data we got back, we did not see, I mean, it's hard to tell if someone was, because they're answering a survey, confused about that, but when we did the cognitive interviewing with the survey, we did not get people who were confused after they read the question and understood the, who was providing what type of service. So hopefully that. But I do know a lot of facilities are changing like scrub colors, like, nurses might be blue and rad techs might be, I think Hopkins uses fuchsia or something. But just very different colors so that to avoid that confusion. So thank you for the question. Thank you. Oh yeah.
Is there a proposed timeline in which you're going to start using this patient satisfaction survey?
No, there is not. Thank you. Yes. Yeah. The question is there any benchmark data? So the only data that we have is the data from the 2 survey testings that we've done. And that was for, 65 IRFs were for that one, for the largest one. So out of, was there 1,400 IRFs? Almost 1,200, okay. So not very representative, so we would not have benchmarking. But with the survey we have found in the results is that generally the patients and the processes are rating fairly high for the care that they receive, which seems indicative of quality care that they're getting. Generally, scores have been for what, and on the website there is an executive summary, so you can actually see some of the results. But generally, the scores are, like out of a rating of 10, they're generally like 8, 9, 10 for a lot of these items, or strongly agree that the care they received was, good or something like that. So generally. Fairly high from what we saw with those 2 different testing that we've done so far. Any other questions? No? Okay, great. Well, thank you for your time.